Good day, everyone. For those of you who doesn't know me, my name is Severos Yasaiko II, practicing physical therapist here in the state of Florida. The purpose of why I came today is I finally realized that I'll be able to help more people through media. Today, I have invited board certified orthopedic surgeon Dr. Timothy Evans, who will share to us about some common questions you may have about knee replacements. So stay tuned and let's learn from him. Good afternoon. Today I have here with me Dr. Timothy Evans of Central Florida Orthopedic Surgery and Associates. And again, Doc, thank you so much for taking out of your time to have this interview. And, for I know you have a busy day and for giving me this opportunity. Before we start, can you tell me about yourself and what you got into medicine and why orthopedics?
Yeah, so I was born in New Jersey. I've got older brother. We lived there until I was about 9, and then we moved down to South Florida at that point. Did most of my growing up down there, and then I went to school in Florida for my undergrad, and then kind of bounced around the Midwest and everything for my medical education. Ended up in Detroit where I did my training, and then back down here I did a fellowship in musculoskeletal oncology at Moffitt Cancer Center in Tampa. I got into orthopedics mainly because, I mean, it's much more mathematical, I think, than a lot of the other medical subspecialties, and I have a pretty mathematical mind. And it also is probably a little bit more technical in terms of, the understanding of like the instrumentation and everything is much different than all the other subspecialties. So I think that's what drew me to it the most. I mean, the focus on biomechanics and more kind of engineering or physics principles too. So I mean, those are the things that drew me towards it. And then some personal experiences and everything kind of guided my path into going into musculoskeletal oncology. And here we are.
Wow. And I mean, you took the kind of the more difficult route, like oncology, musculoskeletal oncology. Why not just the typical, degenerative? But man, you took that route.
Yeah,
You're more on that.
I mean, I still do a lot of the, total hips, total knees, total shoulders. But I think the cancer training also kind of adds another component to my practice that, I think that gives me the most fulfillment in terms of helping those patients. I mean, it's great to see everybody do well, but those patients especially.
Good. Thank you. Doc, the patients I usually see from you are hips, knees, replacements, revisions, and even complex ones. And I'm new here in Florida, Doc. And the first time I heard your name is have this patient that have been through different surgeons. And I don't want to say her name, but she's a lady. And she went to different surgeons here, orthopedic surgeons, and it wasn't healing. She still has pain. Then eventually she was just getting so frustrated and been, hopping from one surgeon to the next. That's why I first heard about you. But do you do other joints or surgeries aside from those, lower extremities ones?
Yeah, so I mean, with my oncology or my tumor training, I mean, that kind of has caused me to get very comfortable really operating anywhere in the body. Like I said, I mean, I do a lot of shoulder replacements, hip replacements, knee replacements. I do a relatively large amount of like trauma surgeries and stuff too, although I mean, some of that stuff sometimes is a bit above my pay grade, and I'll kind of defer to the orthopedic traumatologist for some of that stuff. But I do a little bit of all of that. I think it helps kind of maintain a lot of those principles that I use during my oncologic procedures. So I think there's some advantage to kind of continuing to do all of that.
Good. Thank you, Doc. Let's talk about, knee replacements. I know this is very common, and I think in the US about 700,000 a year, right? Knee replacement.
Uh-huh. Yep.
Yep. So, what do you think are the signs, or when would you decide that this patient need a total knee when they come to you for consult?
I think the non-operative ways to treat that, and this goes for shoulders, hips, and knees, is using anti-inflammatory medications, activity modification, albeit obviously most people aren't going to want to give up doing the things that they love doing.
Hmm.
Physical therapy, injections into your shoulder with steroids, and then for the lower extremity patients, using a cane or a walker as needed as well. I mean, when you exhaust all of those options, I mean, I think it's really up to the patient as to when they are ready to proceed forward with total knees. I mean, if they've tried at least some or all of those, excuse me, non-surgical approaches and they still are having persistent pain or other symptoms or having some sort of impact on their normal daily life, and they have physical exam and radiographic findings consistent with arthritis, I think it's a reasonable approach. But oftentimes the conversation goes, I don't tell the patient when they're ready, the patient tells me when they're ready. So often it's, I kind of defer to them and they'll come back and see me if and when they are ready to proceed with their joint replacement.
Okay. Doc, I think there's good research out there about obesity and osteoarthritis. Do you kind of require your patients to be at a certain weight before you would operate on them?
Yeah, BMI of 40 or less.
Okay, good. Thank you. Doc, are there any criterias that you would look into to help you decide, this person who would have good outcomes post surgery?
I think just piggybacking off the last question, I mean, patients with an elevated BMI have elevated risk for perioperative and postoperative wound complications or surgical site infections. With any patient, I mean, the risk of an infection in a total joint is probably somewhere in the 1% range. So, I mean, that's going to be elevated to almost 10% patients who have an elevated BMI or who are obese. Outside of that, I mean, patients with diabetes, if their diabetes is poorly controlled, once again, healing complications and everything that comes along with that. So I'll normally say a hemoglobin A1C of 7.5 or less. And then cancer patients or patients on rheumatologic medications or who have a diagnosis of an autoimmune disease or chronic steroids, whether that be for an autoimmune disease or for COPD or any number of reasons. I mean, those are patients who are going to have a depressed immune system and be at elevated risk. Now, that's not to say that I will refuse to operate on any of those patients, but they'll be treated a little bit differently in terms of what antibiotic medications they get perioperatively and especially postoperatively.
Hmm. So technically, you don't say no to a patient. You just kind of manage what they're having presently and take them to where they should be before you would operate them.
Correct.
Good. Thank you so much for that, Doc. The first patient that I've handled that was referred by you, it's through another agency. Yeah, he had diabetes, obesity, and I think she gained weight because she was still having pain because of that previous or from the previous surgery of a different surgeon. And but you still took on the challenge and go like, wow. Yeah, it was, I mean, she's doing so well now. She doesn't live far from where I am. And yeah, they're really doing so well, working in her community. And like,
Very
wow.
good. Yeah.
Thank you. Yeah. Doc, patients, when they are discharged to home or surgery, 2 to 4 days post op, and I often hear this from them, I don't want to take my pain meds because I don't want to be addicted. Can you comment on this, Doc?
Yeah. So, I mean, I think, this is kind of multifold, but I will say, I mean, it's very difficult to get addicted to something that you're only taking for several days. I mean, obviously, patients who have a prior history of narcotic or substance abuse will be treated a little bit differently than those who don't. Granted, a lot of patients who I had that conversation with do have a relative or close friend or something like that that has struggled with substance abuse in the past, and they're obviously concerned that it would happen to them as well. What I tell them is, we provide you with a short course of narcotic pain medications because you do need them. I mean, orthopedic surgery is extraordinarily painful. And I think, it's more important to me, for them to be comfortable enough to be able to participate in therapy and be able to get around well and those sorts of things instead of abstaining from taking any pain medications and then being, basically confined to their bed because they can't get up and move and all those sorts of things, especially for the first few days after surgery. So, I mean, I don't think there's a huge risk in terms of taking them for a few days while you're initially recovering. But I mean, that's also why we have a protocol in place at the office where they get a 3-day supply and they can elect to take those around the clock for 3 days, or they can elect to try and spread those out over the course of many days too. And I mean, that's the other thing is that I give other medications to reduce your need for the narcotics. So anti-inflammatory medications, Tylenol, even medication for neuropathic pain, such as like gabapentin or pregabalin. I mean, those are other options as well too to reduce your threshold for needing that narcotics. So it's a little bit of all that.
Good, thank you. Doc, thank you for that. What about if a patient, Doc, I know you mentioned about addiction, what about a patient who's, I wouldn't say, who would take alcohol 3 times a week? Would it be different from someone who's substance addiction? Would you treat them differently? Or
Yeah, I mean, a little bit. I mean, so it depends on what your definition of alcohol abuse is. I mean, I think technically it's one alcoholic drink a day every day of the week for women, like greater than that, or two per day for men. If I'm not mistaken, it's somewhere thereabouts, but that's kind of ballpark. But I mean, I think as long as they're beneath that threshold, I don't really look into it further. Now, obviously, if they're binge drinking or drinking socially, but they don't know when to stop, I mean, those are other problems as well. But those are conversations that are had that, you need to be off these medications. And I kind of explain to them the risks and the benefits associated with it. Because, I mean, if you are on those in terms of using alcohol or other illicit substances, I mean, that's obviously going to have a significant impact on your outcome.
thank you, Doc. Thank you. I know we're almost close, Doc. Doc, what would you, 68-year-old, this is, kind of hypothetical patient, 4 months post total knee, no assistive device, decent knee ROM, 0 to 105, able to do what she needs to do for his or ADLs, but still complains of minimal pain, not the same pain prior to surgery, swelling, there's still swelling, and stiffness. What would you tell this patient?
How far out is she from surgery?
4 months.
Yeah, I mean, if she's 0 to 105, I think you said 4 months after the surgery and still reporting pain and stiffness. I mean, I think I would tell her to probably give it more time. I mean, that's actually it's not exactly where I want my patients to be at 4 months, but it's not so far behind that I think she would require any intervention or anything like that. I mean, I think there's still time to try and get some more of that range of motion back. And I mean, if you look at relatively stiff knee like that, I mean, the options are either do nothing and try and get more motion with therapy, try a manipulation under anesthesia, which at 4 months, I don't know how effective that's going to be, or do a revision, which I mean, a revision obviously, I don't even think should be an option. I mean, I would also watch her too. So over the course of the next several months, if her pain persists, then I would probably work her up and make sure she doesn't have a prosthetic joint infection.
Okay. Thank you, Doc. This one, Doc, what would you say a 62-year-old patient whose ultimate goal, after knee replacement, go back running, jogging? I know some patients I have that they just want to do this again or even learn a new sport like pickleball. Very common here.
Yeah, yeah, yeah.
What did you tell
Yeah,
them?
I mean, I would say, I mean, there's whenever you do like high impact activities like that, running, jogging, even pickleball, like cutting sports. I mean, you're gonna put more demand on those implants, and you're gonna increase the risk of wear and those sorts of things. Now, I mean, with the types of new ultra high molecular weight polyethylene that we have, I don't know. I haven't personally seen like excessive wear from them, and in terms of like the first or the most recent studies that I'm aware of in terms of wear rates for them, I mean, it's less than, a tenth of a millimeter per year. So I think, whenever you do those sorts of things, the patient needs to understand that they're increasing their risk for, loosening and failure and potential revision. But at the same time, I mean, people need to live their lives. I mean, I think as long as they understand the risks and you tell them the risks and they choose to do it, I mean, ultimately they're an adult. I mean, they can make their decision however they'd like to make their decision. I'm not going to, the whole point to doing the procedure is to get them back doing the things that they love that they aren't able to do anymore because of the arthritis. So to put limits on them like that to me doesn't make a lot of sense.
Okay, so you would kind of encourage them as long as they're into it.
Uh, yeah, I don't know if I would encourage them. I would just kind of make sure that they're aware of the risks that they're taking and say, it's possible, but I mean, you do assume a risk that, you do wear this knee out quicker than usual.
Yeah,
Nothing's guaranteed. I mean, you
right.
could choose not to do any of those activities and then wear it out, or you could choose to do all those activities and not wear it out. So no one has a crystal ball, but all we can do is kind of use the knowledge and the statistics that we have at hand. So
Good. Doc, how long is you said there's a recent or a new ultra prosthesis something? What's a typical span there, or how long does it usually last?
like the polyethylene.
Yeah, polite.
So the lifespan is predicted to be like 25 years. However, there's been some, like I was just saying, I mean, the wear rates are less than one tenth of a millimeter every year. So in some of the more recent studies where they actually like go retrieve some of these implants after they've been in for a while, they show wear rates even better than that. So I tell my patients 25-year lifespan just because I think that's sort of the lifespan of the cement mantle and everything to a cemented total knees. But yeah, I don't know. I think the longer we go with this new generation, like the recent generation of implants, I think the more we'll be impressed by their lifespan.
Wow, yeah, 25 years. That's long. Yeah. Doc, I think it's my last question. How can we get hold of your practice?
So I mean, we have a general line, so I can give it to you if you'd like.
Okay.
Uh, it's 863
863
666
666
3436.
3436. So that's 863 666 3436.
Yep.
Good. What's the name of your practice again, Doc? Central.
Central Florida Orthopedic Surgery Associates.
Thank you very much, Doc. Thank you
You're
very
very
much.
welcome, man.
And what I'm gonna do, Doc, is I'll keep you posted. Of course, your what's this, Miss Vicky as well.
Yeah.
And really thank you for this opportunity. You taking out of your time, and this would surely benefit. I'm so involved in our church family, and I'm gonna share this with them.
Yeah, absolutely. Thank you very
Oh,
much, man. I appreciate you taking the time.
yeah, thank you so much, Doc. It's my pleasure.
All right. Take care.
Bye bye, Doc.